Dr. Zachary Flynn, how are you?
Pretty good, sir. How about yourself?
I'm doing well. Thank you. Thank you. Thanks for joining us to talk about Achilles tendon ruptures and Achilles tendon injuries and Achilles tendon stuff.
Yeah.
Just to start, as a podiatrist, the Achilles tendon is a substantial part of your practice, I understand.
Yeah, so Achilles tendinopathy, tendonitis, tendon tears, that's one of the more common things that we treat, especially out here in Arizona. We have an active weekend warrior community, active pickleball community, active hiking community. And so we deal with it quite a bit, and it can range from just heel spurs on the back by the Achilles to full-blown Achilles tendon ruptures. And so we're well versed in it and happy to help these people.
Very, very interesting. And it just seems like every other month, some famous athlete is rupturing their Achilles. You gave a great interview on Clay Thompson's Achilles rupture and long 10-month road to rehab. Thank you for doing that. Very, very interesting stuff. Well, I'd like to go through just some of the more common questions about Achilles rupture in particular, just to pick your brain and get your thoughts. And the first is just the most basic question of all. You're doing something, your ankle, your foot and ankle hurt, you suspect you have an Achilles tendon rupture. How do you know? How do you know before, when you're home in your living room, that you have an Achilles tendon rupture?
That's a great question. Most patients that come in with this pathology, when you're talking to them, interviewing them, they all know when it happens. The initial thing is you've never sustained an injury quite as catastrophic as this one, typically in this patient population. And so when your Achilles tendon goes, the most common thing that we hear is, I got kicked or I got hit by something. And then I reach down to the back of my leg, and it's very simple. Like, you reach down there just above the back of your heel, you can feel your Achilles. And every patient, when they rupture it, you can feel what we call the dell, which is the defect in the tendon. And so when you think of the Achilles tendon, it's kind of like a piece of celery. Like, if you go to the store, you buy a stalk of celery, you break off an arm. It's pretty similar like substance. So, you go to dice the celery and you cut it and then you separate it. That's what the tendon does. And so the fibers are supposed to be aligned. And then when it ruptures, they separate and they retract. And so it's very, very noticeable. And then you're going to notice an instantaneous decrease in power. And you're going to be like, okay, something bad happened. You're going to sit down, you're going to be pushing on it and be like, uh-oh, you had the oh darn moment.
Well, and the Achilles tendon is so involved in the kinetics of normal gait. A lot of people are under the impression that if you tear your Achilles tendon, you actually can't walk. Can you walk if you tear your Achilles tendon?
Yes, you can walk. The biggest thing is you're going to notice that decrease in power. The best example I can tell patients is, you hop on YouTube, type in Kobe Bryant Achilles tendon rupture, and you're going to watch the video of him. He goes to drive past the defender and he feels his Achilles tendon goes. He goes down to the ground and he asks Paul Gasol, he's like, hey, did Harrison Barnes kick me? And he said, no, he didn't kick you. Kobe reaches down. He's like, oh, darn, I've ruptured my Achilles tendon. He gets up, shoots the 2 free throws, and then walks himself to the locker room. And so that's a prime example of, you can walk afterwards, but it's not a normal gait pattern. You're not able to propulse from the calf muscle complex, but your upper thigh and everything can compensate to where you can still ambulate. Now, I would request that you don't ambulate, because it's not ideal for your tendon, but it can be done.
Very interesting. Well, okay, we're at that moment where the oh darn moment, as you call it. You realize, you reach down, you feel the defect in your tendon, you know for sure what's happened. What if you do nothing? Can it just get better on its own? Can you just leave it like that? Will it heal up? What would happen if you don't do anything?
So the Achilles tendon, depending on the severity of the rupture, it can heal in what we call by secondary intention or secondarily. The recommendation, the standard of care in the United States and in Europe, if the patient is healthy, active, and ambulatory, or any of the above, the recommendation is surgical repair. And the reason for that is a lot of data and a lot of studies. I mean, you look at American Journal of Orthopedics, foot and ankle surgery, sports medicine. The re-rupture rate in those tendons that are allowed to heal secondarily sits between 30 and 40%, which is way too high for any patient that I want to treat. And so if to restore functional ambulation, you surgically repair it. The few times that I don't surgically repair it is it's a low-grade rupture, and it's a patient that's a very sick individual, multiple comorbidities, advanced heart disease, advanced kidney disease, that just would be a poor healer in general. And then it's safer not to do the surgery than do it. And so it's a rare occasion, but it can happen, but we wouldn't recommend it typically.
So if you're medically fit to have the surgery, the recommendation is to have the repair surgery. If you're so ill that you're at high risk to undergo surgery, you're probably not going to be dunking the basketball anymore anyway. So you don't need that higher level of function, so you're okay. All right, well that makes sense. So I'm at that moment. I realize it's torn. It is all of a sudden my gait is off. I think a lot of people would have a tendency at that moment to sort of panic. And when you panic, you go to the emergency room. Is that the right thing to do for this? Is there anything they can do for you in the ER? Should you bother with that? What's the recommendation?
The typical care that they're going to receive in like an emergency room or urgent care facility is, like right now in the COVID situation, I would tell a patient an Achilles rupture is very obvious. It's happened and you're going to get referred to a surgeon. And so I would just call the surgeon or your primary care doctor and try to avoid those critical service areas. In the post-COVID world, I would also advise that if you have an Achilles tendon rupture, ultimately, no matter what step you take, you're going to end up in my office or in a colleague's office to get surgical repair. And so as long as there's no traumatic laceration or traumatic opening or some critical element, if it's just an isolated rupture, stay off of it, ice, elevate, call your PCP or call me and I'll get you in basically ASAP. Patients that call my office that have sustained an Achilles rupture, I just tell them, how fast can you get here? Because I want to see that patient, get them protected, get them immobilized, and then get them ready for their surgery. And so not that urgent care, facilities are bad or emergency rooms are bad. You're just going to get a prescription for pain medication, probably a muscle relaxer, and then get sent on your way. Some facilities will do an ultrasound to confirm the rupture, but it's pretty obvious. I prefer MRI anyway because it really guides our surgical plan. And so it's just way easier to kind of save yourself the time, keep you protected. Because when you have the rupture, you're either at home or on the side of the mountain. You got to walk to your car, walk through the parking lot at the emergency room facility, walk back. The more you're on it, the worse the tendon retracts. And so I just say, go home, take it easy until I see you.
And it sounds like because the tendon does retract and, you got to walk to the car to drive to your, you can't, it's hard to get around without using your foot, as you know very well. Yeah. So really someone needs to be seeing you within hours to a day or so. This isn't the kind of thing, I'm going to give it 3 days to see how I do. No, we need to pick up the phone now, call, get in, get treated, get on the OR schedule and get it repaired.
Yeah, exactly. The way I always approach every trauma to the foot and ankle is, the sooner I can get to it and the sooner I fix it, ultimately the sooner you start recovery and the quicker you're going to get better. And so that's why I try to really get them in the same day because, say you ruptured on a Monday, I want to have you on the OR table by Wednesday. And then I want you coming out of your cast in 2 weeks with stitches out. And so you just want to kind of get the ball rolling because, that tendon ruptures, it's going to retract the more you're on it. The bigger the gap is, the more retraction there is, the harder the repair. Well, the harder the repair, the longer the recovery, and the less happy your surgeon is because it was way harder than it needed to be. And so really avoiding all those obstacles just only enhances the outcome and the recovery. That's why you jump on it.
So before we get to the OR, and I want to know from you exactly how you repair them and what goes on there. What role does MRI play? Does every patient need an MRI? Is it just in certain cases, or who gets an MRI and who doesn't? And how do you use that information?
That's a great question. When I was a resident, we never MRI'd them. We just went in there, we kind of met with the patient, and we said, hey, listen, you've ruptured your Achilles tendon. When we get in there, these are the means of fixing it. And depending on how severe it is, when we get in there, we'll dictate, what we need to do. I call that like a gift box, like practice, where it's like, hey, I'm going to open you up. And when I get in there, we'll see what was under hood number 3. That's just not my style. And so I always MRI the patient. I like to show them, the MRI. And so the reason I MRI them is I like to go in and just execute the game plan. And so it's like, okay, this is what I need to do to get this Achilles back together, repair it, and get the patient a good outcome. And I need this tool, this tool, and this tool. And I have everything set and ready to roll. And so the shorter OR time, it's better care, and then ultimately you're enhancing the outcome. And so as long as the MRI is not going to significantly delay the surgery, then I definitely recommend getting it. And then outside of the MRI, just make sure the patient is optimized and ready for the surgery. The surgery itself is honestly not super difficult. The nice thing about the Achilles tendon is there's no what we call like deep dissection. It's right underneath the skin. There's not a lot of structures back there that you can cause harm to that would really like jeopardize or increase the risk to the patient. Most Achilles tendon repairs that are low grade, we're actually able to do them percutaneously. And so there's a few different devices available on the market where you can basically make a small incision. You're talking like a centimeter to 2 centimeter incision. You use basically a jig to capture the tendon, and then you can basically do what we call a knotless repair, where you use anchors into the back of the heel bone to help support and keep the tendons together and let it heal. More complex, like moderate to severe grade ruptures, we basically are indicated for open repair. Open repair, you're looking at like a 9-10 centimeter incision, and then we got to open up. And so what you do is you basically stitch the two tendon ends, and then you pull them together, and then you basically tie them. After I put the tendon ends together, I typically support that with some type of graft material, whether it's an allograft or some type of supportive growth product, just to help reduce scar tissue and enhance tendon healing. Typically, where the rupture occurs, the blood supply is poor, and then the layer that supports the tendon called the peritoneum, it's destroyed or non-viable because of the rupture, and so it can get quite complex. And also in severe grade ruptures, you also have to do tendon transfers, where we would take the tendon that supports the big toe, gives it flexion power, and then we can anchor that into the heel bone to kind of make up that power deficit. And so there's lots of little recipes on how you fix it. And I use, the patient, what are their demands, what are their needs, and then how bad is the rupture, and the MRI helps guide that. And so it's kind of like that puzzle piece that you have to use to get that perfect outcome.
Very interesting. And I mean, and it again goes back to the quicker I get in and the less retraction, the less complicated it is, the more options I have on the simplicity of the repair and kind of getting back to it. Mm-hmm. Well, I mean, I realize if I'm a Joe average weekend athlete or even inactive person, I'm going to have a different recovery than an elite athlete like Klay Thompson or Kobe Bryant. But what is the recovery from surgery like? How long till I'm back to normal? And would you mind just kind of walking us through what are the stages of it? What is that recovery like, and how long does it last for an average person and then for some kind of super athlete?
Yeah, no, that's a great question. So we've covered kind of everything up until like, okay, we get you on the operating room, we've put the tendon back together, now what? So, depending on the severity of the rupture, I would say 90% of these patients, they're going to be immobilized in a splinter cast for 2 weeks. We bring them in, we cut the cast off, we take a look at the skin. Skin's good, we take the stitches out, we put them back into a cast. Almost all Achilles ruptures are casted for a minimum of 4 weeks. After 4 weeks, as long as the skin's good, the tendon is behaving itself, then we would start passive range of motion, where we put the patient into a walking boot. They're not walking yet, but what we're starting to do is fire the tendon, fire the muscle, get them into physical therapy, start working on the tissue, keep the Achilles stimulated. And we want to prevent any scarring or adhesions. We want that tendon to be fully functional. We just put it back together. Now let's aid in its healing and stimulate some blood flow. Normally, we will continue the passive range of motion and the non-weight bearing, normally until about post-operative week 8. After post-operative week 8, we initiate like assistive device supported walking, and so crutches with a knee scooter and a walking boot. And then we would ramp up activity. That period of time will extend about 6 weeks. And so you're looking at post-op week, 12, 14, and then we ditch the assistive device. We're still in the boot. Patient's doing really well, we start to phase out of the boot, and we start to kind of increase and ramp things up. Physical therapy is really the long and tedious part of it. And so most patients are back into a shoe between post-op week 12, week 16. Physical therapy for this is you're looking at 3 to 6 months, pretty standard. I normally with physical therapy will either start the patient on an Alter G treadmill where they're kind of suspended just to start getting the tendon engaged while controlling the amount of load going through it. The alternative to that is like aquatic therapy. Get them into the pool as long as the incision's good. Start loading the tendon, but offload it with buoyancy, and so keep them kind of suspended. Engage the tendon with low weight, low activity, and then just advance from there. It is a long and tedious.
It is. Sounds a lot, very extensive. I mean, compared to other major injuries like ACL reconstruction or meniscus or hip, labral tear, shoulder, this is a long recovery.
It's a very, very long recovery. You look at all the data or like athletes that are recovering from ACLs. And so there was a string of ACL tears in the NFL, and they're all on track to start playing early next season and be ready for training camp. You look at those Achilles tendon players, basketball, football, some of them don't come back and play again. The other ones are still doing rehab, and return to play is like 10 months, where ACLs sometimes in the patients are down to like 7 to 9. And
Yeah.
so it's very, very long and tedious. Most of the time, patient completes physical therapy for 3 months. They'll kind of start to advance activity, resume normal life. And I would say probably a good 50, 60% of the time, they need like I call it a touch-up therapy session. They go back to therapy for 4 to 6 weeks. And this is all about calf muscle power. Most of those patients are still complaining about, well, it's still my bad leg. It's still the weak leg. And we really expect that for about, 12 to 18 months, sometimes 24 months, depending on the host patient. And so it's very long and tedious, and it's just the nature of the Achilles tendon. It's just the area where the rupture occurs has poor blood supply. It's very slow to heal. And so we just have to take our time, be patient with it. And that's really the complexity of the Achilles comes from the slow healing, because none of the other stuff with it is overly challenging to the surgeon or to the doctor. It's really challenging to the patient because of we're Americans, we're impatient. We want it fixed and done. And that's just not how the Achilles behaves.
Yeah. Well, celery, it's hard to heal celery.
Yeah.
Well, that's exactly what I wanted to know. Thank you so much for the time today. We will look forward to more foot and ankle talk with you in the future.
Yeah, looking forward to it. It's great having me. Thank you.